Perdón. Ahí voy, permítanme. Ahí están todos. Ahí creo que está el doctor Lee también. Bueno. Ahí voy, ahí voy. ¿Sí me están escuchando?
Sí, doctor.
Ok.
Sí, doctor.
¿Están viendo mi pantalla? Sí, ¿verdad?
Sí, ya se ve.
¿No escucharon? No, ¿verdad? ¿O sí escucharon?
No se escuchó nada, doctor.
Ok. Ahí va. Compartir sonido de la computadora. A ver, ahorita me dicen si escuchan. ¿Sí escuchan?
Sí, doctor.
¿Sí escucharon? Ok, perfecto. Vamos a empezar. Impacto de colchicina en enfermedad cardiovascular.
Dear colleagues, welcome to this session dedicated to new studies on colchicine for acute coronary syndromes. As you probably know, colchicine is an old anti-inflammatory drug that is especially known for the treatment of gout attacks. More recently, colchicine has become a new cardiovascular drug for its anti-inflammatory actions for the treatment and prevention of pericarditis, where it is now a well-established first-line agent to be used in all patients with acute or recurrent pericarditis. Later, the colchicine use has been explored in chronic coronary syndrome and more recently also in acute coronary syndrome. In this case, its use is intended as a new anti-inflammatory agent for atherosclerotic plaques. And in this session, we will review and comment on two sub-studies of the COLCO trial, a large randomized controlled trial published last year and exploring the use of colchicine in patients with acute coronary syndrome. And we will also review a new study from Australia, the COP study, reporting results on the use of colchicine also in the patient with the acute coronary syndrome. So let me introduce the first speaker. It is my pleasure to introduce Professor Marie-Pierre Dubé from Montreal, Canada, who will present the COLCO pharmacogenomics sub-study.
My name is Marie-Pierre Dubé. I'm at the Montreal Heart Institute in Canada. I'll be presenting pharmacogenomics of the safety and efficacy of colchicine in cold cut. On behalf of the cold cut investigators and all research collaborators, I'm happy to present this pharmacogenomics sub-study of cold cut. Here are our disclosures. Inflammation plays an important role in atherosclerosis in the process leading to and following a myocardial infarction. In cold cut, colchicine reduced the risk of ischemic cardiovascular events by 23% in patients treated with colchicine compared to placebo. Here we present the pharmacogenomics sub-study with the objective to identify patients more or less likely to derive benefits from treatment with colchicine and to gain some insights into the underlying mechanisms responsible for the response to colchicine in patients treated who have coronary artery disease. Cold cut was a placebo-controlled randomized control study that compared colchicine 0.5 milligrams to placebo in patients following a myocardial infarction. There were 4,745 patients in this trial. Of those, 1,656 consented to the pharmacogenomic study. We further excluded a few individuals, including those who had a genetic ancestry other than European. This left 1,522 participants for the pharmacogenomics study. We further excluded those patients who were not compliant at 80% through the first 6 months of treatment for the analysis of cardiovascular endpoints. Baseline characteristics were comparable between colchicine and placebo groups. Patients were mostly male. Mean age was 60 years. Background therapy included aspirin, other antiplatelet agents, and statins. For the pharmacogenomic study, we used the primary cardiovascular endpoint as defined in the COLCA trial as a composite of CV death, resuscitated cardiac arrest, myocardial infarction, stroke, or urgent hospitalization for angina requiring revascularization. For the genome-wide analysis, we included 702 patients treated with colchicine who were compliant through the first 6 months of medication. This was done to reduce noise and increase statistical power for detection of pharmacogenomic variants. We also conducted the genome-wide association study with gastrointestinal adverse events. The most common adverse events for patients treated with colchicine. We used all available patients for this analysis, as we expect the pharmacogenomic variants to be very quick to show their effects. For the genome-wide analysis of cardiovascular endpoints, we did not find a genome-wide significant finding. The top region was an intergenic region or variant here on chromosome 17. We conducted a pre-specified subgroup analysis in males, which identified an interesting region on chromosome 9, as you can see here, which did not quite reach the genome-wide significance threshold of 5.0 times 10 to the negative 8. Analyses were conducted by Cox proportional hazard regression, adjusted for age, sex, and principal components for genetic ancestry. Genotyping was conducted with the Illumina GSA array and imputed against the 1,000 genome reference samples. The GWAS for gastrointestinal adverse events found 2 significant regions, one on chromosome 6 and one on chromosome 10, shown here. For each of the identified region, we then tested the effect of the allele in the placebo group, and we tested the interaction between the genetic variant and treatment with colchicine. We can see here for the interesting region on chromosome 9, the leading variant was an intronic variant in the SAXO1 gene. There was no effect in the placebo group, and there was a significant interaction term. For the GWAS significant findings with gastrointestinal events, for the chromosome 6 region, there was a small effect in the placebo group and a very significant interaction term. Similarly, for the chromosome 10 region, here we had no effect in the placebo group and a significant interaction term. Now taking the view in stratified patient population, looking at the effect of colchicine versus placebo. If we look at our interesting region on chromosome 9, male individuals with the protective genotype represented 83% of the population, and those treated with colchicine had 3.2% of cardiovascular events, compared to 6.3 in the placebo group, for a hazard ratio of 0.46. Now for the gastrointestinal events, if we look at patients who were carrying the risk alleles, those homozygous here on chromosome 6, when treated with colchicine had over 36% of gastrointestinal events, compared to over 18% in the placebo group, for a hazard ratio of 2.42. Similarly, chromosome 10 here, individuals who carried 1 or 2 copies of the risk allele represented 13% of the population and had 47% risk of gastrointestinal events when treated with colchicine, for a hazard ratio of 3.98. In the COLCA trial, colchicine reduced the risk of ischemic cardiovascular events by 23%. Now, if we look in the pharmacogenomic subgroup or interesting region on chromosome 9, we see a 54% in cardiovascular event, as shown here on this cumulative incidence graph. We also conducted functional genomic analyses of the identified region. We use bioinformatics software, including COLOC, FindMap, and PhenoScanner. And we found that the chromosome 9 region overlaps the SAXO1 gene, the stabilizer of axonal microtubule 1 gene, which is involved in microtubule binding. The leading variant at this locus was an EQTL correlated with the expression of the House 6 gene, which is involved in microtubule generation from existing microtubule and may interact with the effect of colchicine, which is known to inhibit microtubule formation. Also, the region on chromosome 6 associated with gastrointestinal events was co-localizing with the locus for Crohn's disease, adding further support for this region. Our study had some limitations, including the fact that it is a subgroup of a larger clinical trial and patients may not be representative. Here we see that for the primary cardiovascular endpoints, the subgroup was representative of the main trial with 6.2% cardiovascular events in this subgroup compared to 6.3% in the main trial. However, we note that there were fewer death outcomes in the pharmacogenomic subgroup as compared to the main trial. This may be attributable to delay in consenting patients to the pharmacogenomic subgroup, as this was an optional study, and it could have reduced our power for genetic association with the cardiovascular endpoint. We also note that we had more gastrointestinal adverse events in the pharmacogenomic subgroup compared to the cold-cut population. This may be attributable to correlation in patient willingness to take part in the pharmacogenomic subgroup and patient willingness to share their milder gastrointestinal adverse events. However, we do not feel that this is likely to have impacted the results of our study, as we have seen the interaction effect between the genetic variants identified and treatment with colchicine were quite strong. In conclusion, we report genetic associations for response to colchicine. Those results support future personalized approaches for inflammation reduction in cardiovascular disease prevention and offer interesting lines of investigation for the mechanisms behind response to colchicine. We emphasize that this is a post-hoc subgroup analysis and replication will be necessary before any clinical implementation can be considered. On behalf of the entire COLCA team, I thank you for your attention.
Residentes. Entonces, Eric Morales, si vas a prescribir colchicina en este tipo de pacientes y tienes la capacidad de hacer estudio genético, ¿en qué tipo de pacientes, hombres o mujeres, lo pedirías? Y si es así, ¿qué tipo de cuál cromosoma te gustaría solicitar? A ver, Eric.
Pues el cromosoma que, pues el que más efectos que se vio fue el cromosoma 9 y pues es más en masculinos. Y ahí lo que dice pues es que el tratamiento debe ser personalizado y como se han visto en otros estudios pues igual no todos los pacientes infartados expresan inflamación, o sea que no en todos está el papel o el rol de la inflamación. Esto medido por PCR antiguamente. Y pues nada más.
Perdón, Eric.
So, thank you very much for your presentation, Professor.
Sí, perdón, esto era así más en cuanto a genético, pero creo que nos da un dato interesante, ¿no? Hacia dónde va la medicina cardiovascular. Déjenme ver el siguiente, la presentación siguiente. Déjenme ver cuál es. A ver. Déjenme ver.
Debate was very interesting and important.
¿Dónde estoy? Aquí estoy. Impacto de colchicina en la enfermedad cardiovascular. Colcott Pharmacogenomics, después el impacto del tiempo al tratamiento del inicio de la colchicina en el Colcott. Ok, perfecto. Muy bien. Entonces vamos a seguir viendo este. Y el otro es el COPS Trial, colchicina para mejorar los resultados cardiovasculares en pacientes con síndrome coronario agudo. Perfecto. Ok. Vámonos entonces. ¿Siguen viendo mi pantalla, jóvenes?
Sí, doctor.
Sí, perfecto.
The
Este doctor que está hablando, por cierto, dice colquiquín, pero es colchicina.
Colcott pharmacogenomic sub-study is a post-hoc subgroup analysis of the Colcott trial. So replication is necessary also for the study, as you acknowledged. This sub-study involved about 1/3 of patients of the original trial. Colcott is a large randomized trial exploring the use of low-dose colchicine, 0.5 milligram once daily, in patients with acute coronary syndrome. The study enrolled more than 4,700 patients with a mean age of 60 years. 80% were males with high rates of use of aspirin, statins, and beta blockers and conventional treatment for acute coronary syndrome. The primary endpoint of the study was a composite endpoint, including cardiovascular death, resuscitated cardiac arrest, myocardial infarction, stroke, and urgent hospitalization for angina leading to revascularization. In the main study, the patient treated with colchicine had a reduction of cardiovascular events, and the colchicine reduced the primary endpoint by 23%. In this pharmacogenomic sub-study, we have interesting findings showing that at least one locus on chromosome 9 is close to genes that regulates the microtubule function, regulating binding and generation of microtubules. This is important because we know that the main mechanism of action of colchicine is related to its capability to interfere with tubulin polymerization. And so this sub-study is important for at least two reasons. The first one is that we can have a better understanding of the mechanism of action of colchicine. So it is really linked to microtubule polymerization, so affecting the function of white blood cells, but also the generation and activation of the inflammasome, a cytosolic complex of proteins activating the inflammatory cascade. Second, it is important because pharmacogenomics can help us to better understand the optimal responder to colchicine and the colchicine resistance. So it can be useful for personalized medicine leading to the proper use of the drug for the proper patient. So I would like really to thank the investigators for this interesting study. Of course, it is a preliminary study. We need additional evidence, but this research will probably lead to a better understanding of the mechanism of action of colchicine and to a better selection of patients for colchicine. So let me now introduce the second speaker of this presentation is Dr. Nadia Boudalabui from Montreal, Canada, the same institution, presenting another Colcott sub-study. This Colcott sub-study is the impact of time to treatment initiation of colchicine on cardiovascular outcomes after myocardial infarction.
Hello, I'm Nadia Boudalabui from the Montreal Heart Institute in Montreal, Canada, and I'm pleased to present at the ESC 2020, the digital experience, this time to treatment initiation of colchicine and cardiovascular outcomes after myocardial infarction in the colchicine cardiovascular outcomes trial on behalf of the COLCOT investigators. These are our disclosures. So colchicine is a potent anti-inflammatory medication that binds to tubulin that affects the inflammasome. In COLCOT, colchicine demonstrated a significant reduction in the risk of ischemic CV events compared to placebo when therapy was initiated within the first 30 days following MI. In this current analysis of COLCOT, we aimed to determine whether time to treatment initiation of colchicine after MI had an influence on its beneficial effects on CV outcomes. As a reminder, this is the study design of the COLCOT trial. 4,745 patients were enrolled within the 30 days following an episode of MI. They had to be on standard of care therapy, including at least a statin and one antiplatelet agent. They were treated according to national guidelines, and PCI was performed whenever indicated. Patients were randomly assigned to receive either 0.5 milligrams a day of colchicine or placebo. And in COLCOT, the primary endpoint was a composite of CV death, cardiac arrest, MI, stroke, or urgent hospitalization for angina requiring coronary revascularization. And here is the main result of the COLCOT trial. As you can see, treatment with colchicine in comparison with placebo resulted in COLCOT in a 23% reduction in the primary endpoint with a p-value of 0.02. In this time to treatment analysis, we included patients who received at least one dose of the study medication. Time to treatment initiation was defined as the time between index MI and the initiation of study medication, and 3 TTI strata were analyzed: TTI between 0 and 3 days, TTI between 4 and 7 days, and TTI between 8 and 30 days. The relationships between endpoints and TTI were examined using a Cox regression model. An adjustment was made using the same covariate used in the main analysis of COLCOT. Of the 4,745 patients included in COLCOT, 4,661 were analyzed within this TTI analysis, 2,322 in the colchicine group, and 2,339 in the placebo group. As you can see, baseline characteristics were similar between both groups, with patients being mostly male with a mean age of 60 years. Importantly, background therapy was excellent in the trial, with 98% of patients with aspirin, 99% with a statin. 93% of patients underwent PCI for the index MI. The rate was similar in both groups. The time between index MI and randomization was similar in both groups, and it was of 13.5.
No, se las hace una señal.
¿Alguien tiene el micrófono abierto?
Me fue muy bien porque
Miguel Galicia. Ah, ya. Ok. Órale.
Days. Of the 4,661 patients included in this analysis, 1,193 were randomized between days 0 and 3, 720 between days 4 and 7, 2,748 between days 8 and 30. And as you can see, here are the baseline characteristics of patients broken down according to the 3 TTI strata. There were small differences between groups, and patients randomized between days 0 and 3 were slightly younger they were more frequently smokers, and they had less diabetes. And here is the main result of this time to treatment initiation analysis of the COLCOT trial. As you can see, early initiation of colchicine led to a 48% reduction in the primary efficacy endpoint versus placebo after a mean follow-up of 22.7 months. The p-value was of 0.007. And when modeling the relationship between TTI on the x-axis to the adjusted hazard ratios on the y-axis using a quadratic model, you can see that the earlier therapy is initiated, the greater is the benefits. In the subgroup of patients in whom colchicine was initiated early, these are the effects of colchicine on the components of the primary endpoint, on the secondary endpoint, and on the exploratory endpoint of all coronary revascularization. As you can see, the results on the primary endpoint were due to a lower incidence of MI, a lower incidence of strokes, and a lower incidence of urgent hospitalization for angina requiring coronary revascularization. And when turning to the pre-specified secondary efficacy endpoint of the trial, which consisted of CV death, cardiac arrest, MI, or stroke, early initiation of colchicine led to a 45% reduction in this secondary endpoint when compared to placebo, with a p-value of 0.031. This work has limitation, the main one being that chosen TTI strata may not reflect all post-MI trajectories. In addition, a larger trial might have allowed for a better assessment of individual endpoints and subgroups. In conclusion, in this time to treatment initiation analysis of the COLCOT trial, early initiation of low-dose colchicine after MI led to a significant reduction in the risk of ischemic CV events by 48% when compared to placebo on top of standard of care. We believe that our results support an early in-hospital initiation of adjunctive therapy with colchicine for post-MI prevention. Thank you.
Thank you very much, Dr. Bulla Dallabui, for this nice presentation. This COLCOT sub-study explores the effects of the early administration of colchicine on cardiovascular events in the COLCOT trial. And I think this study is very important, addressing an important question, that is if the early use of colchicine can improve the outcomes, cardiovascular outcomes. In my experience in patients with pericarditis, the early use of colchicine can really improve the capability of the drug to treat and prevent pericarditis. And in this sub-study, we observed that in the overall trial, colchicine reduced the primary outcome by 33%, while in the subgroup of patients with an early treatment within 3 days, colchicine was able to reduce the primary outcome by 38%, so with improved results, with improved outcome. So it seems that the earlier seems the better, and this sub-study really supports the early initiation of colchicine after an acute coronary syndrome. This sub-study is very important because probably gives us also the idea that in cardiovascular application, the early use of the drug could improve the outcome. So really, thank you very much for this observation that I think is very important for clinical practice. And now it is my pleasure to introduce the last speaker, Dr. Jamie Leyland from Australia, presenting the COPS trial, colchicine to improve cardiovascular outcomes in acute coronary syndromes.
Hi there, I'm Jamie Leyland, a cardiologist from Melbourne, Australia. It's a pleasure to present to you colchicine to improve outcomes in patients with acute coronary syndromes, the Australian COPS randomised trial on behalf of the COPS trial investigators at ESC 2020, the digital experience. I have no conflicts of interest which relate to this presentation. So following an acute myocardial infarction, there remains an ongoing risk of future cardiovascular events. And this was elegantly shown from the widely disseminated Swedish registry, which is highlighted on the left-hand side here, that showed that following an acute coronary syndrome, there remains an ongoing 20% risk of further events out to 12 months. Now, there are many factors which contribute to this ongoing risk, such as patient factors, compliance, participation in cardiac rehab. However, there has been significant interest in the last decade in the role that inflammation has to play in predicting future cardiovascular events. We can see here on the right that the risk of death and acute coronary syndromes following a myocardial infarction actually increases with higher levels of residual inflammation, as shown here with high levels of CRP. Therefore, this has led researchers to specifically target inflammation in order to try and improve this 1 in 5 or 20% risk of future events in acute coronary syndrome patients. Indeed, this is exactly what the paradigm-changing CANTOS trial demonstrated. Professor Ridker and colleagues elegantly showed that when the selective IL-1 beta antagonist canakinumab was administered to high-risk patients, there was a significant reduction in hsCRP, which translated to significant reductions in major adverse cardiac events. Now, canakinumab is a highly selective and expensive anti-inflammatory agent, and there are many other anti-inflammatory agents available. Colchicine is a very widely used anti-inflammatory agent, which is commonly used for the treatment of gout. And not only does it work on the IL-1 beta pathway, but it also has other anti-inflammatory properties. Now, its potential use in cardiovascular disease and improving patient outcomes was really brought to the forefront with the LODOCO trial, which is shown on the left here. The investigators demonstrated that in patients who received colchicine as opposed to medical therapy, there was a significant improvement in outcomes in the longer term. And the same investigators also demonstrated that in patients who are on high-potency statins, the addition of twice-daily colchicine for 4 weeks led to significant reductions in highly sensitive CRP. These early findings really led us to potentially use colchicine to try and improve outcomes in patients with acute coronary syndromes. And this is why we envisaged the COPS trial, which was developed in early 2015. Our hypothesis was to determine the effect of colchicine when commenced during the index hospitalization for acute coronary syndromes on cardiovascular outcomes. And our primary endpoint was the composite of death from any cause, acute coronary syndromes, ischemia-driven urgent revascularization, and stroke at 12 months. The design was very, very simple. In order to get into the trial or to be eligible, you had to have a hospitalization from acute coronary syndrome, had to have an angiogram demonstrating at least a 30% stenosis, and have either stent or medical therapy. If you had surgical disease or you had a contraindication to colchicine, then you are not eligible to go into the trial. Now, this is a patient's perspective of what happened. They were hospitalized for an acute coronary syndrome. They had an angiogram. They received PCI or medical management. And if those things occurred, then they were approached to be involved in the study. And if they consented, they were randomized to receive placebo plus optimal medical therapy or colchicine plus optimal medical therapy. And they were reviewed at 30 days to see if they were having any issues with the medications at 12 months, 2 years, and 5 years for major adverse cardiac events. The dose of colchicine was 0.5 milligrams twice daily for 4 weeks, followed by 500 milligrams, 0.5 milligrams daily for 11 months. Dose reduction was allowed in the first 4 weeks if patients had significant side effects. So the trial was run from December 2015 to September 2019 across 17 recruiting centres across Australia, which were predominantly academic centres. We screened 2,167 patients to give us our final study number of 795 patients, 396 patients in the colchicine group versus 399 in the placebo group. Patients were followed up by structured phone interviews from the main study centre in Melbourne. So these are the results and the baseline characteristics of the cohort. You can see that they're well matched, these patients, with similar baseline characteristics, similar medications. This was predominantly a trial of STEMI and non-STEMI, which were the predominant diagnoses. And it was also a trial of PCI over medical therapy, as 87% of the patients actually received PCI. So at 12 months, there were fewer events in the colchicine group compared to the placebo group. However, this did not reach statistical significance. However, due to the way we conducted the study, 90% of the follow-up was performed at around, or over 90% of the follow-up was performed at around 365 to 400 days. So we're actually able to accumulate data out to the sensor date, which was 400 days. And at this time point, there was a late accumulation of events in the placebo group with separation of the Kaplan-Meier curves, and the trial became significant statistically. If we look at the individual components of the primary outcome, which is the secondary analysis, the reduction in events in the colchicine group was predominantly driven by reductions in acute coronary syndromes, stroke, and urgent revascularization. However, there was an increase in non-cardiovascular death amongst the group. In the per-protocol analysis, which was pre-specified, which included only patients who were actually taking the study medications, there was a significant benefit of being on colchicine with a hazard ratio of 0.43. Again, if we look at the 400-day data, 41 events in the placebo group versus 24 in colchicine, with reductions in ACS, stroke, and urgent revascularization. So COPS demonstrated a reduction in major adverse cardiac events at 365 days, but this was not significant, but became significant at 400 days. And we saw an increase in events really after 365 days when, in fact, colchicine was discontinued. And this raises the possibility that perhaps colchicine is having some underlying plaque stability or plaque modulating effects, and this is translating to reductions in target vessel revascularization, acute coronary syndromes, and stroke, but this is merely hypothesis generated. We did see a higher rate of non-CV death in COPS. Now, Colcott, released last year, a much larger trial, had similar death rates between the placebo and treatment groups. However, they had a differing dosing schedule with daily doses of colchicine and a longer duration of follow-up. It's possible that our higher death rates, although small, did reflect the higher dosing schedule, but most likely represents shorter duration of follow-up and the smaller sample size. We are planning on doing at the moment longer-term follow-up of COPS patients. So in conclusion, low-dose oral colchicine in addition to standard medical therapy during hospitalization and continued for 12 months resulted in a lower rate of the primary composite outcome, but this was not significant statistically. However, an extended follow-up to 400 days resulted in a significant reduction in the primary endpoint, predominantly driven by reductions in stroke, urgent vessel revascularization, and acute coronary syndrome. The higher rates of non-cardiac death warrant further investigation and temper the overall positive findings, and hopefully we'll decipher more of these findings in the longer-term follow-up. Many thanks.
So thank you very much, Dr. Lehnen, for this presentation. In the COPS trial, about 800 patients with an acute coronary syndrome were enrolled. The mean age of the population was about 60 years. 80% were males, and 50% of them were patients with an ST segment elevation myocardial infarction. Colchicine was used at a dose of 0.5 milligram twice daily for the first 4 weeks, and then followed by once daily up to 1 year. And the primary endpoint was a combined endpoint, including all-cause death, acute coronary syndrome, stroke, and ischemia-driven revascularization at 1 year. So overall, the patient population was very similar to the population presented in the Colcott trial, but the trial is smaller and the dosing of colchicine is probably higher. So the main results of the trial are that a non-significant reduction of events was observed at 1 year in patients treated with colchicine, but statistical significance was reached with prolonging the follow-up up to 400 days, and better outcomes were observed also in the per protocol analysis that included only patients who were able to tolerate colchicine. One important remark to the author is that we don't have data on side effects, and this probably would be important to assess better the tolerability of the dosing proposed in the trial that is higher compared to the Colcott study, because in the COPS trial, patients were treated for 1 month with colchicine 0.5 milligram twice daily, not only once daily as in the Colcott trial. So overall, we can say that we have some evidence of possible efficacy of colchicine with results that are overall similar to the Colcott, but the smaller size of the population and the shorter follow-up probably can explain the less brilliant results compared to those reported in the Colcott trial. In addition, it is important to remark that higher doses of colchicine were used at the beginning of the treatment for the first month, and this higher doses could have compromised the efficacy of the drug and increased side effects, but we don't have data on this, so it will be interesting to read the full paper where the authors will report probably also the side effects and the safety of the drug. So once again, thank you for this additional experience on the use of colchicine in acute coronary syndrome. And let me conclude that I would like to thank all the speakers for their nice presentation. I think very important for this topic. I would like also to thank all the audience. In this session, we had 3 interesting studies, 2 subgroup studies of the Colcott trial showing the importance of the pharmacogenomic in the study of colchicine efficacy. The second one reporting the importance of the early administration of colchicine within 3 days from the acute event in order to improve the outcomes. In the last study, the COPS trials, we had additional evidence that colchicine could be useful in patients with acute coronary syndrome. So let me conclude that thanking all of you and the speaker for these presentations, and thank you very much to all of you.
Muy bien. ¿Comentarios, residentes?
Sí, doctor,
Comentarios de estas
pues
presentaciones. A ver.
sí, pues la verdad que se ha demostrado que tiene pues un beneficio la terapia con colchicina. Todavía quedan varias interrogantes, ¿no? De exactamente cuál es el mecanismo en el específico en el síndrome coronario agudo. Ya vimos lo que hablaron al inicio del inflamosoma, la asociación benéfica del análisis del cromosoma 9 y demás análisis de genómica que pudieran orientarnos hacia ver cuáles pacientes son los que pudieran ser candidatos a esta terapia y que se beneficiarían más de la misma. Pero pues hacen falta, como bien han repetido en diferentes ocasiones los doctores, que pues, son necesarios estudios más largos. Ya aquí vimos que una estrategia pudiera ser iniciarlo una dosis más alta las primeras 4 semanas y después disminuir la dosis a la mitad a 0.5 miligramos al día. Sin embargo, ahí en ambos estudios vimos que las curvas de mortalidad por todas las causas no son tan distintas entre los pacientes que se sometieron al tratamiento y aquellos que fueron tratados con placebo. Entonces yo creo que ya se demostró que tiene beneficio el fármaco. Sin embargo, falta afinar más detalles para determinar cuáles son los mejores escenarios para usarlos y cuáles van a ser los desenlaces a largo plazo.
Muy bien. ¿Quién más?
Sí, doctor. Pues ya habíamos discutido el estudio. Es un estudio bueno, el Colcott. Este estudio que publican donde la mortalidad posterior del año se les aumenta, y no saben ellos tampoco por qué se les aumentó. Digo, saltan muchas cosas a la mente, pero podría saber, es un fármaco inmunomodulador. Entonces, puede ser una de las respuestas por lo cual es tal vez la respuesta inmune del huésped se vea disminuida, el inflamado no pueda ser capaz de reaccionar contra distintas, tal vez infecciones, alguna otra cosa, y eso sea la muerte de origen no cardiovascular. En cuanto al tiempo de inicio, pues dentro de los primeros 3 días, 0.5 miligramos cada 24 horas. Creo que la única diferencia que hay en el estudio donde se les aumenta la mortalidad o comentan el aumento de la mortalidad es donde les inician 0.5 pero cada 2. Entonces, pues sí, esa es una de las diferencias que saltan a la primera vista. Tal vez mejor dejarles 0.5 cada 24. Y el tiempo de cuánto le vas a dejar ese fármaco, o sea, híjole, llevarlos hasta un año y después decir, bueno, ya el año ya no, digo, yo creo que eso nos lo va a ir dando la experiencia y los próximos ensayos que realicen, cómo les va a los pacientes que solo duran 6 meses o duran el año y después lo descontinúan, o creo que esa experiencia la va a ir dando el tiempo. Pero recordar que es un fármaco que se puede unir al arsenal terapéutico para esos tipos de pacientes, que si bien no reduce el infarto, sino la isquemia y la que va a conllevar a revascularización, siempre el paciente debe ir a revascularización, ya sea quirúrgica o por intervención, ¿no? Nunca decir, bueno, pues mejor le vamos a dar fármacos y entre eso le aventamos colchicina, ¿no? Sino que se revascularice y ya después de todo el kit de fármacos que va a llevar para el tratamiento, pues bueno, podríamos pensar en colchicina como un fármaco para disminuir los desenlaces cardiovasculares.
¿Alguien más?
Pues nada diferente, doctor. Sí.
A ver, Ricardo, aquí, ¿por qué en esta curva dicen que es mejor temprano que más tarde, si es una curva que va subiendo y luego va bajando? Como la recuperación económica que dice que vamos a tener la observadora.
Bueno, es que esa es la del hazard radio. Entonces, acá cuando se inician los primeros días está más bajo. O sea, hay una reducción en el riesgo.
Ok. Sí, cada vez estamos viendo más frecuentemente este grupo de curvas, ¿no? Y cuando se acerca acá, ¿qué quiere decir?
Pues ahí está el riesgo incrementado. De hecho, se acerca al 1 y ahí pues ya no hay ningún beneficio, no hay ninguna diferencia entre darla o no.
Claro. Acuérdense que estos son los puntos de los intervalos de confianza. ¿Sí? Al 95%.
Sí, ahí las ponen como al revés, ¿no, doctor? Hacia abajo pues sería asociación positiva con el desenlace, y hacia arriba asociación negativo, y en medio, como dice Ricardo, pues no asociación con lo que se está estudiando.
Exactamente. Ok, muy bien.
Aquí,
sí.
Exacto.
Dime, Ricardo.
Sí, eso. Iba a decir lo mismo que Ponchito. En realidad, pues, ¿a quién se lo vamos a dar? Y de hecho hizo un comentario al final el presentador en relación a las características de los pacientes. Entonces, igual hombres mayores de 60, 65 años, con infarto con elevación del ST. Resumen de los dos estudios, pues dosis bajas al principio. Mantenerlos, pues no sabemos, igual el estudio fue 1 año, pero pues probablemente vayan a continuar el seguimiento en estos pacientes y después veamos esos resultados. Entonces, dosis bajas, esos pacientes, y pues a ver qué sale. Digo, no tenemos la posibilidad de hacer estudios moleculares genéticos, entonces eso yo creo que queda fuera. Y probablemente no sea ni práctico.
Sí, lo interesante acá sería que me gustaría que las sociedades de cardiología estuvieran trabajando para hacer. Desafortunadamente en México, bueno, pues la terapia de reperfusión de los zika son trombolisis antes de la pandemia. Y después de la pandemia creo que ya ni trombolisis ni nada de nada. Entonces sería interesante ver cómo están evolucionando pacientes que venían utilizando ya colchicina por tratamiento de gota, por tratamiento de X o Y, cosas que no son llevados a una revascularización. ¿Verdad? Sería interesante ver si en realidad se medio da un poco de evidencia que ya vinieran utilizando colchicina y que tuvieran una evolución mejor, pues todavía reforzaría mucho los hallazgos que se han tenido de estos estudios, ¿no? Y la diferencia del estudio australiano y de los canadienses, una parte, pues obviamente la estamos viendo aquí, ¿no? Incluidos en el grupo de colchicina, 2.322 pacientes, incluidos en el grupo placebo, 2.339, cuando el grupo de los australianos ahí incluyeron solamente como 700 y tantos pacientes, ¿no? Porque sí también no hace ahí algo así, no es muy congruente que a los 365 días no tienen una diferencia significativa y que a los 400 sí. O sea, ¿qué pasó? O sea, en realidad todas las diferencias están dadas en el otro, junto con este otro, por la N, ¿verdad? Por el número de pacientes. ¿Ok? Bueno, muy bien. ¿Algo más? ¿Algo más? Miguel Reyes, Eric.
Pues ya me parece que todos los comentarios son muy similares, ya los que mencionaban mis compañeros. Llama la atención, hay que esperar, a ver, digo, se ha ya demostrado su beneficio en cuanto a la respuesta inflamatoria, pero vale la pena esperar a ver qué pasa después de cierto tiempo de uso de la colchicina en los pacientes, la dosis adecuada que deberíamos emplear en ellos, y también ver la tolerancia, porque como lo mencionas, es el tratamiento de manera individualizada, o sea, no perder el enfoque del tratamiento con antiagregación plaquetaria, las estatinas, y de manera adicional, pues añadir el uso de colchicina, dependiendo también algo lo que tenemos aquí limitado para la realización de estudios genéticos, pues ver la tolerabilidad de los pacientes, porque en algunos de los pocos pacientes que lo hemos utilizado aquí en el hospital, a primeras dosis han tenido eventos gastrointestinales. Entonces hay que esperar eso, la evolución a después de un año, y el tiempo ideal y dosis adecuada para el manejo.
Muy bien, perfecto. Bueno, ok, jóvenes, pues no nada. Pónganse de acuerdo si quieren que revisemos pueden ustedes elegir. Bueno, me dicen, elijan si quieren que revisemos algo más del Congreso Europeo el jueves, para verlo, ¿no? ¿Okay? O si quieren revisar algún artículo, nada más habrá que mandarlo, ¿sí? Si quieren podemos ver el de los síndromes isquémico coronario crónico, ¿verdad? Colchicina, podríamos revisar algunos que salgan en New England recientemente, ¿no? Y bueno, pues parece que todo va ahora hacia la modulación de la inflamación, ¿no? La inflamación residual que queda en los pacientes después de los síndromes isquémicos coronarios agudos o crónicos. Bueno, muy bien, entonces mañana a las 7 continuamos con el programa de cardiología intervencionista, y el doctor Vidal mandó una ¿cómo se llama? Puso en el chat lo de las clases que se están llevando a cabo por parte de en pregrado. Obviamente